Welcome to the annual Build Exito and URISE Research Symposium. I'm Tom Keller. I'm the principal investigator for both Build Exito and the URISE program, and I'm delighted to welcome you to this event. The Research Symposium is an important milestone for our scholars. You get to share the impressive research that you've been doing over the past year. You gain skills in reporting and sharing your research, and it's great preparation for future conference presentations and maybe publications. So we have several groups with us today. On the Exito side, we have cohort 6 scholars who are just completing summer immersion. So they have been in their RLC placements for a year, and they will be reporting their research from the past year. We also have cohort 7 scholars who are just finishing up their summer induction, which means they're just beginning their RLC placements, and they get a preview of what it will be like next year when they're presenting at the symposium. And finally, we hope that we have many prospective cohort 8 scholars who may have attended the Summer Research Academy and are in the process of applying for Build Exito right now, so they can see more about what the program is all about and the kind of research that students do. So welcome to all of you. On the URISE side, we have cohort 1, our very first URISE scholars who have been in their research placements for the past year, and they're just coming off of an intensive summer research experience. So they will be sharing their findings with us. And we also have cohort 2 scholars in URISE who have just started their research placements this summer. So they've been in their RLCs for just a couple of months, but we asked them to do their presentations as well because we think it's good experience, and they will be sharing with us the research that they intend to do over the coming year. So another group I hope we have with us today. It would be wonderful to see research mentors who have supported and guided our scholars, and we really appreciate the opportunities that they're providing for our scholars, and we hope that you enjoy seeing and supporting your scholars during the symposium. And we want to also acknowledge some scholars that will be concluding the program soon or already have. First of all, Miriam Ibrahim completed with us in August, and Raisha Paris is completing Exito at the end of immersion, and Emily Mize is completing at the end of fall term. So congratulations to all of those scholars. I also want to thank people that are involved in making this all work, putting on this great event. So first of all, Dr. Decatur Foster has done an excellent job with summer immersion this year, supporting the scholars in preparing their presentations and posters. I also want to thank Dr. Shandy Dixon, who supported immersion, but also is responsible for induction this year. Of course, there are many other people involved in organizing an event like this, so I want to especially note Cassandra Ramirez and Sarah Taylor for helping to coordinate everything, and many others who have helped to pull this all together. So we're very excited to be together in person again, and I want to say finally, we are very excited about our event on Thursday. So again, the symposium will feature research presentations today, Tuesday, and then the first 2 hours on Thursday. But the last hour on Thursday, just before lunch, we're going to have a poster session and a reception with refreshments. And this year we've combined it with our annual kickoff event to start the new year. So we hope you can all be with us to celebrate. And we've invited many guests from around campus so that they can learn more about Build Exito and URISE programs and see the wonderful research that our scholars are doing. So again, we hope to see you all for that. And We hope you're having a great experience in the program, and we're so proud of all that you've accomplished, and we hope you enjoy the symposium. Thank you.
So first up, we have Ana Martinez, who's going to present on preclinical evaluation of vaginal cells for cancer prevention.
Good morning, everyone. My name is Ana Martinez. I am part of the first URISE cohort, and this past summer I had the pleasure to work with Dr. Reina Petrova and her lab at Brigham and Women's Hospital in Boston, Massachusetts. The project that I worked on is called Preclinical Evaluation of Vaginal Gels for Cancer Prevention. Cervical cancer is the fourth most common cancer among women. The main cause of it is a viral infection called human papillomavirus, most commonly known as HPV. As you can see in this diagram, once HPV is introduced to the epithelial cells, in a matter of weeks, you are HPV positive. For the majority of people, specifically 9 out of 10 cases, the immune system is able to fight it off, and within 2 years, the HPV is able to clear. However, in those other cases, after having 10 or more years of this reoccurring or persistent HPV, it can become cancerous, and at that point, it's considered high risk. The main and current prevention method for cervical cancer is the HPV vaccine. And although it is extremely effective, it has its own limitations such that it's generally not offered to women over the age of 26. And according to the CDC, as of 2018, only 51% of teens are fully vaccinated. Therefore, the goal is to find a device that is safe to use for women of all ages, but that is also affordable and accessible. I want to briefly explain in simple terms a little bit about the vaginal microbiome. Essentially, there is good and bad bacteria, and there are a lot of species of the good bacteria, but the one that's most commonly found throughout everyone and is called Lactobacillus crispus, and this is the one that we use in our experiment. We call it the good bacteria because it's going to provide or be able to give the environment a low pH, which is going to act as a barrier against pathogenic bacteria and yeast from multiplying too quickly. The ideal pH range, as you can see, for the healthy one is between 3.8 and 4.9. Whereas on this side of the diagram, as you can see, is the unhealthy vaginal microbiome. And here we see much lower levels of this good bacteria and higher levels of the bad bacteria, such as the purple one, Prevotella bifida, or the blue one, Gardnerella vaginalis. Dysbiosis is a term that is used to describe when there are higher levels of the bad bacteria compared to the levels of the good bacteria. A dysbiotic environment can lead to bacterial vaginosis, which is a common diagnosis among women that is associated with increased inflammation in the genital mucosa, thus increasing one's susceptibility to sexually transmitted infections like HPV. In this study, we assessed 3 different vaginal gels and how they might potentially affect the vaginal microbiome. The first gel is currently under development from a small women-owned company, and although the name of it can't be released yet, I will refer to it as the prototype gel. An NIH grant funded Dr. Petrova and her lab to assess the safety of this gel using an in vitro model. This in vitro model included the use of, bear with me on this one, bioengineered human cervical vaginal epithelial tissues that we call VEC tissues. They were separately colonized with both types of bacteria and then later exposed to the 3 different gels. Those 2 other gels are over-the-counter lubricants that are already available for purchase. The first one is Refresh, that dark purple one, and then Trimozan. The epithelial tissues that were colonized by the bacteria and exposed to the gels were plated onto agar plates, and the bacterial colony forming units that formed that we refer to as CFUs were counted by several lab technicians, and then the counts were averaged and used for data analysis. Here are the graphs that represent those CFU counts. Note that each bar color represents a different gel. And those first 2 columns are 2 different time points where no epithelial cells were introduced yet. So essentially it was just the bacteria, whether it was the good or the bad one, and the gel. Column C represents those once the epithelial tissues were introduced. And in the first row, those top three, L. crispatus, that is a good bacteria. So essentially, we would want to see higher levels of it. The prototype, which is in red, you can see helps support its growth of it, whereas the two over-the-counter gels, the green and the purple, suppressed its growth by more than 50%. And the second row, we have L. ginsengii. This is also another good bacteria. And here again, we see red, the prototype gel, supporting the growth of it. Lastly, the last row, P. bivia, that's a bad bacteria. Here we can see that we would want to see lower levels, and when exposed to the epithelial tissues, the over-the-counter gels were able to suppress their growth. In summary, the prototype appeared to be safe and non-toxic to the good bacteria and the epithelial cells. However, the two over-the-counter gels did suppress the bad bacteria because they also suppress the good bacteria. That's not ideal because it can lead to a disruption of what the healthy vaginal microbiome should look like. Since in this experiment, the gel was tested with both the good bacteria and the bad bacteria separately, it would be ideal to run another experiment where they're both done together, because that's going to reflect an actual vaginal microenvironment where they're both present simultaneously. And there we would like to see if there's a selective growth, and if so, which one is able to grow and thrive better, is the good or the bad. And in regards to the over-the-counter gels, those should be further studied to understand their role in increasing cervical cancer risk, because we saw that it was suppressing the good bacteria, which is not what we want. Here are my sources. And finally, I want to give a special thanks to my mentor, Dr. Fitzgerald, and her entire lab for helping me and guiding me through this project. It was my first time working in a wet lab, so it was interesting. I had a lot of fun, and my interest in women's health research continues to grow stronger. Thank you. Let's open the floor for any questions. Yes.
What kind of author did you use? Kind of agar?
Oh, agar. That's a good question. It was called Brucella Remo. As you can see in this graph, P. bivia. My PI noticed that she had ordered the wrong one after we had run the experiment, and which is why P. bivia didn't grow without the human cells. There's another type of agar that we can use where it would have grown, but because the agar wasn't correct, that's why we see no growth in that program. Yes.
Thank you, Anna, for a wonderful presentation. I was especially impressed at the way you walked us through this slide in particular.
Yeah, it can be a
There's
lot.
a lot of data on there, and you really walked us all through so we could understand what we were seeing. So that's excellent. And you mentioned it was your first time working in a wet lab. So I was curious a little bit more about your role in the wet lab and the kinds of skills that you learned.
Yes, we did a lot of pipetting. My favorite one was the multi-channel one. So like working with that was really fun. The serological pipettes, which is like a little gun that like you section up. She has like a lot of projects going on at the same time. And so we did like trypsinizing, and we fed cells. So I was able to like make the food and like feed them, working in the anaerobic chamber. When we placed the bacteria on the agar plates, that was in the anaerobic chamber, so that was fun. Thank you.
Well, I think we can follow up a little bit more. So am I right in interpreting that it's a good thing it didn't suppress the positive bacteria?
Yes.
But is it really as effective in the type you're trying to prevent? According to those.
What do you mean by the type that we're trying?
The problematic.
Oh yeah, that's what we want. We want it to, like, for example, with the over-the-counter gels, they were suppressing the bad one, but they were also suppressing the good one, which that's not ideal. The best scenario that we could have is it's killing the bad bacteria, but it's keeping the healthy one alive, because the healthy one is going to keep the pH low, which is going to protect against any pathogenic bacteria from continuing to grow.
I'm curious about the messaging and just communication towards the population of women that you're trying to reach? So did you talk in your lab about what types of things women should be aware of who either are or are not vaccinated? And could you just say a little bit more about that?
Yes, there's like a lot of like things about like the vaccination and how it, like if it's the 2-dose or the 3-dose, and depending on when you get your first one, at what age, and if you've had HPV or not. But there's a lot of practice that women should be aware of, definitely, especially taking care of the vaginal area. Douching is one of the things that is highly, it's like, if you don't know what douching is, it's the washing out of the the vagina with water or any other solution. It's highly discouraged. And one thing that I found interesting was, the box is really small, but in the refresh box, the one that's already, you can buy it at Target or any store. That one, it says use after douching, which I think is very misleading. And I looked into like how at the FDA, like I was asking myself, how is it that like it's available to everyone if you're not like you're being misinformed about it, it's dangerous to be using it. And the FDA passes them as like cosmetics, which is why they don't have as many restrictions on it. But yeah.
Thank you.
I guess a follow-up on that, do you know if there are any efforts to try to make that not the case? Because it seems really harmful to have products like this on the shelf.
Yeah, I have looked a little bit into it. This study, that's what it's trying to do, is preventing women or like putting something that's good out there, which is why it's gonna need a lot of testing. Like I know there's gonna be another part of this project where they're gonna do like clinical testing where they're gonna test it on women's arms. And see like how they react to it, but also if they're most likely going to use it, because what's the point of having a good project if women are like, well, I don't know how to work it, I don't think I'm going to be using it, it's too complicated, things like that. Yes.
I just got a little confused. So the two products there, they're aimed for women with what? Like I know, right? Like cough drops, like if it hurts, but what are these for again?
These are just gels, so it's like a lotion type of thing. And it's like a one-time use. You apply it to the vagina area, and yeah. It's just to keep it like healthy and getting rid of the bad bacteria and keeping the good one there. Yes.
I mean, I guess it's just, the only thing I can really say is, it's just like kind of what you were actually around policy around health. Like, these products are being given out, there's no information basically around women's health to be educated appropriate. Yeah, I would assume so. Just because critical care is so important around gender health, and women's health has always been basically neglected to certain extents around information. So how do you personally, has your research team, like, how do we promote better health around these types of things, I guess?
I would say, that's a pretty big question. I think, no, it's okay. Like one of the things that I think about is like Hispanic women and how they can be easily misinformed when like research stuff, like they can easily get told like this doctor recommends it and like that's it. That's all they have to hear from me. Just like I would have never known. I would have been like, oh look, it says all these things, like it has like that medical seal on it. Like I would have bought it, right? So I think like having it accessibility like Spanish and in simple terms, and just even like I think the use of social media to talk about these topics is very important, especially for younger girls.
I'm just curious too, along that same line, do you ever all talk about in the lab about like Oregon has pretty decent supposedly sex ed care or, sex ed classes in schools? And I went through it when I was younger and I still think it's sorely lacking.
Yes.
So, it seems like this kind of information would be something that if we're trying to reach like younger women, sex ed should include this kind of stuff. Do y'all ever talk about like the educational aspect of this and how it can be, other than social media, like got to the younger population so they're growing up with healthier habits?
Yeah, in terms of education in Oregon, we didn't talk about it because this lab is in Massachusetts, so
Okay.
across the entire country. But I agree with you in that it should be talked about more in like at least like high school and those first health classes that girls are joining in and participating in. I think that is very important.
So can you tell if there are any questions from people on Zoom?
Oh,
want to make sure they have a chance. Okay, great, thank you
Thank
so
you.
much.
All right.
So, pleasure to introduce Martinez, another Martinez scholar who's going to talk about youth opioids, longitudinal investigation, the contributing factors in the development of opioid disorders. Go.
Dr. Keller. Hello and welcome to my presentation on youth and opioids, a longitudinal investigation into contributing factors in the development of opioid use disorders. My name is Becky Martinez, and today I'll be discussing a study currently underway in the Advancing Pediatric Pain Research Lab at OHSU. So why is understanding the factors impacting opioid misuse in adolescents important? Over half of recent drug overdoses for 15 to 25-year-olds involve opioids. The rates of prescription opioid use disorder, or OUD, are high among adults prescribed opioids for chronic non-cancer pain. It's possible misuse may be even higher amongst adolescents. Even when taken as prescribed, adolescent opioid prescriptions have a 33% increased risk of transition to OUDs, and 70 to 80% of youth who transition into OUDs or report prescription opioid misuse received an initial opioid from medical providers. So what are the study aims? There are surprisingly little data on the nature of pain medication prescribing within pediatric medical settings and adolescent outcomes, despite this being the place that most youth are introduced to prescription opioids. To address this gap in knowledge, my lab has begun the first longitudinal study focused on adolescents over a 2-year period with check-ins every 6 months to understand and characterize family, peer, and adolescent risk factors. And the next slide will discuss more background information. I've broken down a theoretical model here that informs this study. The next 3 figures represent factors relevant to opioid prescriptions and pain experiences over time. Within pre-existing contextual risks, you'll see family risk factors, including things like whether parents have chronic pain or substance use problems themselves, peer risk factors, including having peers with higher substance use, and adolescent risk factors include factors like psychological distress and having chronic pain. Next, we'll see post-prescription risks and protective factors. Medical factors include things like receiving opioid refills and higher opioid doses. One example of an adolescent risk factor would be having a positive subjective experience with opioids. Protective factors for adolescents include things like higher pain self-efficacy and using over-the-counter or non-medication pain management strategies. Moving on to peer factors, these include things like having easy access to opioids through peers. And lastly, in our model are family factors. These include things like how much parents monitor their adolescents' use of opioids and how they store medication. The introduction of opioid prescription combined with pre-existing risk factors may lead to a higher likelihood of chronic pain and disability, increased opioid use, and opioid-related problems. Who do we want to participate in this study? The current study recruited generally healthy adolescents aged 14 to 18 years who are prescribed opioids for acute pain in pediatric outpatient medical settings. Ultimately, the goal is 300 adolescents and a parent or guardian, and as of 2020, 139 participants are currently enrolled. Adolescents and their parent or guardian will be contacted and enrolled in the study within 72 hours after prescription. These dyads are recruited through outpatient, day surgery, emergency department, and dental clinics at OHSU and Legacy Health. Multiple scales and survey types were used, including the patient-reported outcomes measurement information system and timeline follow-back assessments, which have been shown to be valid means of assessing substance use. All data collection was conducted through telephone interviews and secure online surveys, including daily diaries, which is how the lab collected data on opioid use and mood symptoms. These are some of the initial results from the 139 participants. I know it's a lot of data here. 90.9% of youth filled the opioid prescription, and of those who used the opioids, the frequency of use varied widely from 10% to 100% of days. There were no differences between sexes in the percent of opioid use days, despite females reporting higher pain and mood symptoms than males. Greater pain experiences and number of pills prescribed were positively associated with opioid use as reported in daily diaries. On to some of our hypotheses. Post-prescription adolescent resilience factors will attenuate the association between peer risk and adolescent opioid outcomes over 2 years. Family factors will mediate the longitudinal association between family history risk and opioid use. And having peers with access to opioids and low perceived risk of harm create greater impetus for opioid use for adolescents. Let's summarize. Since many youth are affected by pain and opioids, using information about opioid consumption in pediatric samples might be used to help inform and standardize prescribing practices, which is recommended to reduce overdose risk in pediatric populations. We're still learning, which means that more longitudinal work will be needed to disentangle the role of psychological factors. I'd like to thank the ARPP lab at OHSU for help with this project, and thank you for your attention. This concludes my presentation, but questions can I answer.
You used an acronym at the beginning that I'm unfamiliar with. Can you explain what OUDs are?
Yeah, I did describe it, but it went by so fast. That's okay. It's opioid use disorder.
So in your study comparing all the relationship between mental health and you spend a lot of addiction starts as coping mechanisms. And I know the study presents of the organs like third highest in the country for opioid use disorders and also like lowest in the country for access to health issues. Those are like related. So I was just curious if that practice into your study at all.
As far as I know, it doesn't, but that's a really great question, and I can look into it more for you. If you'd like to shoot me an email, I can verify, but as far as I know, it's not.
Yes, thank you for an excellent presentation. I'm curious about recruitment in this study and how easy or difficult it was to recruit these dyads, and also about retention in the study over the longitudinal period, which was also and how at each of those points might be introducing.
I want to hear from them if it goes good.
Yeah, as far as retention is concerned, I think from, if memory serves, it's once COVID began, we saw a great reduction in our ability to even get folks into the study. So originally the intention was to have around 500 participants, but that has increasingly just shrunk down to hopefully 300 at this point. And I think part of that is in part because of retention issues. So yes, COVID has played a major part in that reduction. Yeah.
Thank you.
Yes.
Do you know what your involvement, so this is your first summer on this project?
Yes.
Okay, so do you know what your involvement's gonna be going forward or what you would hope it would be?
Right now, my involvement has been like transcribing interviews, that sort of thing, which I've actually really loved doing. I don't know what it's gonna look like in the future because my participation is this and transcribing interviews so far. So I don't know what it's gonna look like in the future, but I'm excited to do whatever is needed. I think this is a really important topic, so wherever I'm needed is where I'm gonna go. Yeah.
Will you be analyzing the reason that they are on opiates, like the kind of medical condition or accident, and also the prognosis, like if they think it's supposed to be just, a couple days and everything will pass, or if it's going to be a long-term issue? There are plans to look at it in that way.
Yeah, it's basically anything non-cancer pain. So a lot of the interviews that I have personally seen were for folks who had broken clavicle. There's been like anything outpatient related. So it's not necessarily like a specific kind of injury, but it's anything non-cancer pain related.
And what about like those things that are short-term versus longer?
Yeah, I don't know the answer to that. So yeah, I can look into that much.
I'm really interested to hear your thoughts on like what drug policy in Oregon might have as an impact on like retention and recruitment versus if you were like recruiting in a state that had a little more stigma and perhaps like less access for people because of criminality.
Can you repeat that? I'm so sorry. I
Yeah,
missed that
like
last
what,
part.
like what overall, like drug law and policy in Oregon, how that might play a contributing factor to the retention and recruitment of people in the study versus if you were like recruiting in a state perhaps where the laws differ and people's ability to perhaps.
Yeah, I think that that's a really big question that I definitely don't know the answer to fully. I think, I'm sure there are factors that play in the legality of prescribing opioids to younger folks, but I don't know the answer to that, unfortunately.
I'm curious if all of the people involved in the longitudinal study were, if there were any interventions attempted prior to them being in the study. I'm in a pharmacology lab and I've done a lot of research on cessation interventions, like pharmacological ones. So I'm just curious if that came up at all.
This study really doesn't focus on intervention, as far as I know at this point. It's really just post-prescription. So that's what they're focusing on in the study, is just after that prescription has already been written, at that point, let's take a look at the effects.
I'm so sorry if you did say this and I just went over my head, but I was wondering if, based on the data that you guys have, did it seem like the majority of your participants were using their medications properly?
Yes, yeah, I can bring up some of that. It's as far as the 139 participants that we have so far, it's really varied really widely. So there are some folks who use it 100% of the days, and then there are some folks who really don't. And so that's what we're kind of looking at, like, hey, what are those factors that play into that use or non-use? So yeah, it's kind of all over the place as far as I know.
So you're doing this study on children. Okay, like what are the age ranges?
14 to 18.
Okay, so are their parents responsible for administering their medications at home?
It would depend on the family dynamic. So I would assume, well, one of the factors is parental monitoring and storage. So of the medication. So I'm assuming in a lot of family situations, they probably do have a lot of control over when that kid receives the opioid, but then there are going to be other families who don't monitor as closely, and maybe that kid keeps the opioids on their nightstand or something like that. So for use when they, are feeling pain. So it just depends on the diet situation, I guess.
So I'm wondering, like how do you guys anticipate? How do I ask this question? How do you guys anticipate like that difference between like the parents who are administering the medication and the children who are administering their own medication? And like, how do you write that into the data to like make room for like, say a parent withholds medication because they don't want their child to overuse opioids versus like the child that's in charge of their own medication, maybe they take 2 instead of 1. How do you guys differentiate that?
Yeah, a lot of it comes down to how we're collecting the data. And a lot of that comes down to the patient diaries. So the adolescents fill out daily diaries. And a lot of that information is like their pain intensity scale on 0 to 100, when they took their medication, if they took their medication, that sort of thing. So it's all self-reported. Yeah, so that's kind of how we're learning about who's taking their medication, who's administering, that sort of thing.
Do you guys have any like conclusions yet about the no?
Yeah, not really. There's like initial results, but it's so widely spread right now that there's no conclusions just yet.
Interesting, thank you.
So kind of aligned with all these other questions. So it was interesting to me the slide where it was a difference between male and female reported levels of pain. And so since they're 14 to 18, they're already a little bit older and socialized. So just in your lab, and I don't know if they know, but in your lab discussions with the people there, just are there any sort of anecdotal correlations as to why? Because up here amongst us, we can have all these different reasons why there's a higher levels of reported pain with females. But if it's a longitudinal study to see how opioid use disorders develop, I mean, so then it's 2 different groups. I mean, even though there's more than 2 genders, but it's interesting, right? Where they would maybe have to be treated differently terms of cessation or even before that. So I mean, so then my question again though, is there any, from you seeing the data and the interviews and knowing sort of the social background, the diagnosis that were prescribed, like what do you think, just anecdotally, what those differences be?
Yeah,
Besides what you would guess?
my opinion on this is that especially depending on the culture of the individual, specifically for females tend to be more responsible for like family matters or like chores or whatever. So I think it has to do with the level of responsibility that child or adolescent experiences in their home life and outside of their home, of course.
They're more physically taxed, that would give them more pain or whatever this disorder, is that what? Or
I actually think it might be both. And again, this is just my opinion. I think that if you experience a higher level of responsibility, your sense of control for your opioid use might be a little bit higher. So maybe you recognize like, hey, this opioid makes me really tired or makes me really sluggish, and I have this, and this to accomplish throughout the day. So maybe you don't take it at a certain time, or you decide to take Tylenol instead.
so your brain is clear, so you can get your things done.
Right, exactly. And then, on the other side of that is also like, maybe because of those additional responsibilities and higher anxiety levels that we tend to see in females and in this age range and all age ranges, increased anxiety usually does lead to like higher pain. So that's my opinion again, so yeah. Yes.
I might have missed this, but were these subjects experiencing all the same ailments? Like, were they different things that they were taking the opiates for?
Yeah, they were all kind of different situations. So again, we saw one individual who had like a clavicle break, a fracture. There was someone else who had sprained their ankle. So there's different situations for each of the individuals.
That kind of answers my question.
Oh, perfect.
You said at the beginning of your presentation that all of the individuals were quote unquote healthy.
Yeah, relatively healthy.
However, they are experiencing pain to be selected. So I was curious how you grouped the participants. Were there sports injuries, or is it physical pain versus anxiety, mental pain?
It's physical pain.
It's only physical pain.
Right. So enough physical pain that a medical provider would prescribe opioids.
Okay.
And by relatively healthy, it just means like there's actually a whole list that I'd be happy to send you of different things that we were looking at. So shoot me an email if you'd like to kind of get more information about that. But it was, non-cancerous issues, no severe mental health issues, so no diagnosed like depression or anxiety or something like that. So those were kind of the two big ones that I can think of off the top of my head. Yeah.
Is there a specific occurrence that yielded higher usage, like by injury or?
No. Yeah, as far as our data has shown so far, there isn't like a specific injury where we're seeing higher use versus less severe injury.
I have another question to share that, so we always hear with doctors. I know that when they're talking to their patients, this is a different setting. They always, if they're talking about drug use, opioid use, or anything, they can always feel it's safe to sort of in their mind overestimate what the patient is saying. So in your life, you have to report what you're given. But then again, you're like, but what if this teenager is saying, I'm only using this much, but they might be using more.
Yeah.
Right, because it's reality too. So
Yeah.
that's how would you, or like, how do you just put the numbers in that you're given?
Yeah. I think ultimately, yes. I think part of the purpose of having that dyad is to hope for some sort of like accountability between the two.
Right.
But yeah, you're absolutely right. We have to go based off of what the patient is informing us that they're using.
Sorry, we gotta wrap this up. Thank you, Joe. That was it. Thank you. for an excellent presentation and also being so willing to answer many questions. Again, we let you go a little longer to get back on schedule because some people are logging into Zoom according to the schedule. So I think we're in good shape now. Again, we want to encourage that engagement, a lot of great questions. So our presenter is Adrian from the URISE program. And we'll be talking about his research with detail around social connection through crisis context. Thank you.
Hello, everyone. My name is Adrian Stutzman. I'm currently working in Dr. Alan Teo's lab at the VA. This study is titled Increasing Social Connection Through Crisis Caring Contacts, a Pragmatic Trial. Lack of social connection and loneliness predicts suicidal ideations and is associated with a 26% increase in all-cause mortality. Our research team convened a stakeholder group of subject matter experts and veterans who adapted crisis or caring contacts into a new intervention called Crisis Caring Contacts, which addresses pandemic-related social isolation and includes peer support from veterans. Caring contacts is one of only 2 non-pharmacological interventions with evidence of reducing suicide. For this study, caring contacts was adapted into a new intervention called Crisis Caring Contacts. We are trying to determine if caring contacts is effective in older veterans, reduces loneliness, diminishes all-cause mortality, and how a peer support component will affect it. This study is a multi-site, pragmatic, randomized controlled trial, and participants will be from Portland, Oregon, Ann Arbor, Michigan, and the Puget Sound, Washington VAs. The goal is to enroll 920 participants across all 3 VAs. We're going to evaluate whether crisis caring contacts decreases loneliness and the effect of crisis caring contacts on treatment engagement and suicidal ideations. We're going to also explore the potential moderators of treatment response and the effects of crisis caring contacts on all-cause mortality, suicide attempts, and drug overdoses, both fatal and non-fatal. To participate in the study, veterans must be over the age of 60 and have poor treatment engagement. They will be excluded if they do not have a valid mailing address, phone number, or are already participating in another caring contact study. And the outcomes, we are measuring whether this intervention will reduce loneliness, increase treatment engagement, whether there will be increased social support, increased trust in the VA, and whether it reduces suicidal ideations. We will also be measuring whether it reduces all-cause mortality, suicide attempts, both fatal and non-fatal, and drug overdoses, also both fatal and non-fatal. The intervention group will receive 10 caring postcards over 10 months with caring non-demanding messages from peers at the VA. And you can see some example postcards on the screen that they'll be receiving. The Enhanced Usual Care Arm will receive 3 postcards over 6 months with tips, online resources, community, and phone-based psychosocial resources. We hypothesize that the intervention group will have a reduction in loneliness, more social support, and a higher trust in the VA. We also hypothesize that they will have more outpatient primary care and mental health visits and less suicidal ideations over 12 months. Additionally, we hypothesize that the social connection and socioeconomic status will be associated with greater treatment response. I'd like to thank all the researchers who have worked tirelessly on this project, gathering background information, developing this project. I want to thank Team Teo, especially Kim, for assisting me with this presentation. And thank you to Dr. Shandy Dixon, Dr. Decatur Foster for guidance and mentorship. The funding for this project was provided by the NIH and the Office of Scientific Workforce Diversity, and Dr. Teo's work is funded by the Department of Veteran Affairs, Health Services, Research and Development. And this work is solely of the authors and does not represent any views of either funders. And does anyone have any questions? Yes.
So I noticed that there was an age limit. It was 60 and under, right?
60 and over. So that group of people has kind of been left out of the research, and so we're specifically targeting 60 and older.
Okay, how come they've been left out? Just out of curiosity.
I'm not sure. It's kind of the Vietnam era veterans. So I'm not sure why exactly.
How did you narrow down to a postcard as the initial intervention or?
So Dr. James Motto was a psychiatrist, and he wrote a paper in 1957, I believe. And he was a psychiatrist, and he found that most people were committing suicide shortly after getting out of inpatient psychiatric care. And so he started writing them letters after they were released. He started writing them letters and found out, oh, it seems like, it's reducing the suicide rate. And so he conducted a study, and that was the first study that was conducted called Caring Contacts.
Can I follow up?
Yeah.
Has that been compared to like a phone call or random visit to the house? Or?
Yes, there have been some other studies that have included other things such as phone calls, but that's not something we haven't narrowed down specifically to this one thing in order to not confound the variables. Yes.
Will these postcards be handwritten? Or are they like pre-typed material that's sent out to everybody in the study that's the same?
They will be typed, but then they will have there'll be something written on it by the peer support veteran. Yes.
You kind of touched on this, but I was hoping you could expand on it a little bit. So do you know much about what are the risk factors for suicidal ideation in veterans and how this intervention targets that?
I don't think I understand your question for sure.
So talk about suicidal ideation in veterans. Do you know what are some of the risk factors that lead to that in veterans and how this addresses?
No, not necessarily, but one of the factors is loneliness, and there is data that shows loneliness is associated with a 26% increase in suicide. And so hopefully with the reduction in loneliness, by connecting them to a peer, getting them back into treatment, we can reduce the loneliness and also the suicide. Yes.
You mentioned how in one of the predictions that they're predicting that there's going to be more mental health visits.
Yes.
That data, are you guys pulling it from them, letting you know, like, oh, I went to this clinic, or you guys have tests there?
We will have access to the. Yes. Dr. Lynn.
I'm curious, you use language that I'm assuming is carefully chosen, which is that these are going to be carrying non-demanding messages.
Yes.
What is the meaning of that? And is there a particular reason that is sort of phrased? With those words?
So the reason is that we don't want to ask the veterans to do anything. So they can just simply be and know that somebody is at the VA that cares about them. And that's the part of the original study was that they did not demand anything of that person.
So not just like come in for a checkup or
Right.
write me back.
Correct.
Or,
It's not something that we tell them to do something. It's just, hey, we're here, we care about you, and hopefully that will help kind of motivate them.
Yeah.
Yes.
Really nice presentation and great study. Can you help me understand what a pragmatic RCT is versus the more standard RCT you might be familiar with, and how that's appropriate for this particular study?
So a pragmatic randomized controlled trial, they'll be randomized into a control group and a treatment group. But a pragmatic trial is something that we do in real life. So these are real people. We're not just collecting the people for a study and putting them aside, but we'll actually be working with the VA to send these postcards out.
So will each postcard be from, like you said, a peer support person? So they're actually trying to foster a certain connection with an identified individual that.
Yes.
Will there be other contacts with that person besides the postcards?
Well, I don't know for sure. I don't know for sure if the peer support veterans contact information is going to be on there. I'm not sure about that yet. Any other questions? Yes.
In the beginning, you mentioned that you'd be gathered, I don't know if I heard wrong, but something about 3 VAs.
The what?
You mentioned in the beginning that you were getting data from 3 VAs. I don't know if I
Yes.
heard that right. What is that?
So the Veterans Affairs hospitals, they have them in the large metropolitan areas. So there's one here in Portland, which covers Vancouver, all the surrounding areas. And then Puget Sound, Washington, that covers that area. And then Ann Arbor, Michigan, there's a VA hospital there too, as well.
Thank you.
Yes.
In the spirit of being a very lonely person, do you
Yes.
feel like the findings from your study will be translatable to other fields?
I would think so, yes.
Nice.
Right.
Yeah, apologies if you already mentioned this in the beginning as far as like methods. First of all, very important stuff, also very wholesome study and like really special. You identified patients through current care lists, right? Or like current patient lists, right?
Yes.
Okay, just very interesting. Thank you.
Anything else? I do have one in the chat. What proposals or recommendations would be made if hypotheses are proven to be effective? I would assume it would be made into a program or policy that's rolled out through the VA. So I think that's the goal.
So just a bit of trivia. I can see from the slide here that James's colleagues, one of them is Mona, who is from one of our early cohorts, a former Exedo scholar who's getting her PhD a bit of it. So I think we are close enough to the schedule that I can go ahead and introduce this presentation. So it's a pleasure to introduce James Bowe, and he's going to be talking about his research on anti-cancer drug discovery. So thank you, James.
Yeah, thank you. So this is one of my first research projects at OHSU. I work under Mona, and the title was using an in vitro 3D tumor model and anti-cancer drug discovery and efficiency. So the first question was, why do we use a 3D model instead of a traditional 2D model? Since 2D models are more cost effective and they take less time to maintain. Well, we use a 3D model because they are more accurate to the physiological body. So in a traditional 2D model, the cell structures are grown and they are attached onto a surface. So in this first picture here, they're just a single cell layer, and they're typically lay on top of like a flask or a well. In this picture, we have a 3D model. They're more accurate to the body since our bodies are multi-layered. So when we use these models, we can more accurately discover how the drugs interact with the cells. So the main focus of this lab is around acute myeloid leukemia. AML, during AML, the malignant cells, they have an overactive level of beta carotene. And so if these proteins enter the nucleus, it can catalyze an activation that promotes sort of like leukemia development. And so we're using the 3D model to test a drug called gilteritinib. And that's one of the drugs that is used for leukemia. It acts as an inhibitor of the FLT3 protein, and that is responsible for the formation and proliferation of new blood cells. In this experiment, we use HS5 and MV411 cells. So both of these cells are derived from human cell lines. That's important because they give us a good image of how they can affect us. The HS5 cells, they are adherent cells, and the M411 are suspension cells. So whenever we culture the media and passage them, they're a little different. The HS5, they attach onto the plate itself, so that's why they're elongated. And the M4, they're suspensions, so they just float in the media. So whenever we passage the HS5, we have to remove the media and trypsinize them. Trypsin is just used to dislodge them from the plate. We then centrifuge and then add new media. For the MV411, we just centrifuge, add in new media, and just dilute it to whatever population we need. There are 4 conditions we used in this experiment. Untreated HS5, untreated MV411, and treated HS5, treated MV411. So in order to create the 3D cell model, we used a special type of plate. These plates have a special coating on them that prevents the cell from adhering to the plate itself. So right here, traditionally the cells would stick around the well, but since there's a coating, the cells don't have anything to bind on, so they just bind on to themselves, and they create like a cell of a sphere. And in order to sort of get an image of how the drugs affected these cells, we use something called a flow cytometry, also called FACS. This is done in like a big machine, but this is just an overview of how it works. So this is the fluidics model. We use hydrodynamic focusing to push through like single cells. As the cells travel down, they pass through a laser. And so this laser, they shine a light onto the cell, and they can be refracted into forward scatter or side scatter. So a side scatter is dependent on the cell's granularity. So if it's complex and has a lot of internal components, there's a lot of side scatter. The forward scatter is dependent on the cell of the size. Yeah, and there are detectors over here that measures the scatter, and then we can process them in a program called FlowGel. So this is the results we anticipated. I don't have the results on me right now. But from what we saw, there was no significant differences between the 2D and 3D model, which is not what we expected. And so we went over this again. We ran a mycoplasma test and it came back positive. So basically, mycoplasma is something, it's a contaminant that competes with the nutrients and with the cells. So it can affect the DNA and RNA. So that's why we had different results. And we also had a low cell count, which is what we think might be due to mycoplasma as well. But overall, using the 3D tumor model as well as flow cytometry, we can determine the health of cells and see how the different drugs affected the cells. We can also use it to create optimal experimental conditions and see how we can measure drug resistance within the different types of drugs. I'd like to thank my mentor, Mona. She helped me a lot during this. And that's it.
Hi. You
go back to your results slide, I'm curious what you're showing us. Yeah, so this is basically like a heat map of all the cells. In the program, there you can display different sort of data that you collected from the machine. So right here, I think this is like the side scatter and forward scatter. So we just see they measure the let me go back. As the cells go down here, they create like a voltage. That's how the machine measures it. And so this program uses the measure of the voltage to create like an image of the cells. And so this is just like the cells we saw in there.
Do the colors represent different cells?
There's just more of it. The location, like up here or down here, those are different types of cells. So you have like lymphocytes or anything else. There's like debris that we can also see in there.
I see, so the red patch is where that's the most prevalent cell type that you're.
Yeah.
Thanks.
Yeah.
I'm curious, I feel like you really clearly laid out the benefits of the 3D model. How widely studied and used is that model as opposed to the 2D, less effective but cheaper option?
I think it's the 3D models is usually the plates for it are pretty expensive, so it's not used widely, but it's the technology is becoming like more advanced, so there's slowly a rollout of it.
This is not an area of science that I feel very comfortable in, but what would you say the best next step would be to either prove or disprove the value of the 3D model?
I would say we'd probably redo this, redo the experiment. Probably next time we'll test for any contaminants because that threw off our data pretty much. The mycoplasma, I guess we could sort of use like a second trial of it.
For James, I know that's a lot of work in cell culture and it's definitely developing 3D models. You mentioned that you're trying to closely replicate what that environment would do with your 3D models. I'm wondering if you're aware if there are any special additives that you're using to mimic that microenvironment.
I think for this experiment, we didn't use any extra additives. I think the media was I-20 and we just added them for both the 2D and the 3D culture. Any other questions?
Is there any chat or the? So now it's my pleasure to introduce Ismail Basida, who is going to share research on deep brain stimulation. That sounds interesting. Thank you.
Thank you. Hello, everyone. My name is Ismail Basida. Good morning. I will be presenting the research I worked on with Dr. Leah Ernst at the OHSU Comprehensive Epilepsy Center. I'm very excited to share with you our innovative study of deep brain stimulation therapy as a treatment method for non-surgical epilepsy. So what is focal epilepsy and deep brain stimulation? Epilepsy can start at any age, but usually starts either in childhood or in people over 60. Epilepsy is an umbrella term used to describe a brain illness that causes seizures, but under this umbrella term, there's focal epilepsy, which is where only in one half or in one hemisphere of the brain there are recurring seizures. This differs from generalized epilepsy because in general epilepsy, the entire brain is affected. Deep brain stimulation is a pilot method for treating focal epilepsy more adequately by implanting a brain pacemaker gadget into the brain. The signals from the nerve cells that cause seizures are blocked, so the person never experiences the seizure. The goal of this study is to determine whether deep brain stimulation is a viable treatment option for people who have complex focal seizures. Why is this important? Deep brain stimulation would ideally prevent seizures and work in a similar way to treating Parkinson's disease, where impulses are sent to the brain to avoid delayed or uncoordinated movement due to low dopamine levels in the brain. Before surgery, focal epileptic patients will be measured for a stereotactic head frame, which helps keep the head still during surgery. And patients will undergo brain imaging examinations and other medical procedures in preparation for the deep brain stimulation device installation. Patients post-surgery will be assessed after 6 months, and their progress will be recorded. Multiple medical tests and brain imaging are required for focal epileptic patients to ensure that deep brain stimulation is an appropriate treatment option. The patient is awake and alert during surgery, and that is done to assess the effect of the stimulation. An electrode is placed into the targeted areas of the brain and is linked to the pacemaker device. The pacemaker device, which is also known as a pulse generator, is hidden beneath the skin a little lower than the collarbone. Although deep brain stimulation cannot cure epilepsy, it is expected to relieve symptoms following surgery. Regardless, though, the goal would be to improve the quality of life for those with focal epilepsy through deep brain stimulation therapy. Deep brain stimulation is a novel approach of treatment, which means it isn't successful for everyone. However, by getting a better understanding of how seizures work in the field of neuroscience, this revolutionary treatment will enable numerous studies that seemed previously impossible, and deep brain stimulation will soon be utilized to treat epileptic patients. If you have any questions, you can reach out to me via my email, and I'll be happy to direct you further. I would like to give a big thank you to the URISE program for providing me this opportunity, and also to my mentor, Dr. Leah Ernst, and many others for sharing their time and expertise. Thank you.
What's the expected lifespan of the generator?
It actually doesn't have to be replaced. One cool thing about the device is that it doesn't have to be replaced, but you can change the level of intensity, and that's based on each patient and their needs.
Oh, so there's no battery to be replaced?
No. No.
Okay.
So, like you said, it's individualized by every patient. So there's some kind of tuning process that how's that conducted?
Yeah. I explained this further on my poster, so you can see it on Thursday. It can be controlled by the doctor. I explained it in one of the slides. So the device itself is tailored to the patient's needs, and it can take up to 6 months for the patient to find a good spot. But it's something that the doctor can control.
So how do they sort of zero in on the right setting? Is it like, do they use a diary method, or is it like something they can do in real time, or?
I think they use it based off of like their brain chemistry and how past seizures have affected them, and they can adjust how strong the device is. That makes sense. Question?
Yeah, so I guess I work with mice, and we do recordings from the brain. Are these electrodes are they able to record as well as put impulses in?
I would assume so.
Yeah, so the epilepsy we're maybe used to seeing in pop culture on movies is not focal epilepsy, right? That's more the kind of full body, unconscious, visual seizure. Is that kind of right? So I'm just trying to kind of understand the difference a little bit, and I'm curious, and you talked about it at the beginning, but can you say a little bit more about like what is a person who has focal epilepsy experience, or what is it like, or is there a big range?
Honestly, I would say it's kind of the same. The only difference is like where it is in the brain. For focal epilepsy, it's like a very specific spot, and like the title said, it's non-surgical, because if you were to extract that part of the brain, it would like take away life. So it wouldn't be possible to actually take away that part of the brain. And then compared to generalized epilepsy, it's like all over the brain. So like the brain stimulation wouldn't really work for them because of the fact it's throughout the whole brain and not in one spot.
You still might have the same, say, fear of driving a car. Because okay, so it's sort of the same external reality for someone, but it's just how the brain works and why you can and cannot use the deep stimulation. Okay, thanks.
Yeah, and it's been reported by some of the patients where they have a lot of fear and just like in daily activities.
Yeah.
Some patients don't work at all. Some patients just stay at home. Yeah. Okay.
Hi, really nice research as well. This is a really interesting area. I'm wondering how long these patients after the pacemaker has been implanted are followed for efficacy of it, and if there's ever been a situation where the pacemakers had to be removed from a patient before the study's been completed.
Yeah, that's a great question, Dr. Dixon. So currently at OHSU, we had 10 patients. Recently, last month, one of the patients passed away, not because of DBS, but because they had a seizure and they fell, and they hurt their head. But that was one of the patients who had the DBS implanted 3 years ago, and that was one of the more, I guess, longitudinal, you could call it, or long-lasting patients, you could say. But it's definitely over a long time span. And then no patient has ever had or wanted to take the DBS out. On the contrary, a lot of patients have had a significant difference in their lives because of DBS in a positive way.
Thank you.
Okay.
I was actually curious about like, how do you measure that? What kind of, are you surveying people after they've had the implant to see how their quality of life has changed? And is there a particular measure that you use for that?
As for how patients are like, what's the word? Recruited. I'm not sure about that. I just know that OHSU has patients. And then based on like how they're doing, it's more just on their doctor's appointments. They've had like the same doctor. Dr. Ernst is one of them. She's worked with these patients for years, so she knows there's history in a way, in short.
We're really excited to have our next presentation by Avneet, who will talk about autism alerts and what she's been doing with Dr. Zuckerman.
Hi, everybody. My name is Avneet Sidhu. I'm a cohort 2 URI scholar here at Portland State University. And this summer, I was fortunate enough to work under the mentorship of Dr. Catherine Zuckerman at Dornbecker Children's Hospital at Oregon Health and Science University. Our specific project is called Autism Alert, and I'll be sharing my preliminary data with you on the work that I've been doing in understanding variation in parental experience, accessing autism spectrum disorder, also known as ASD, diagnostic and intervention services. So a little bit of background. Autism spectrum disorder is actually, fun fact, one of the most common neurodevelopmental disorders of early childhood. It has an estimated prevalence of about 1 in 44, and it's a lifelong condition that can be detected as early as 12 through 18 months. And this occurs through routine screenings that pediatricians are performing for children at checkups. Early ASD diagnosis and treatment is absolutely a public health priority because the earlier that children are detected and that they are referred to intervention services, they have a higher increased chance of improving language, IQ, and adaptive outcomes. But even though there are all these benefits, we're seeing that the average US child is still being diagnosed years after the first onset of symptoms. So this means even after they're being screened as positive, or that there is suspicion by like either the parent or by teachers that this child might have ASD. Delayed diagnosis and intervention causes a wide variety of problems for both the child and their family. There can be a lower success rate of intervention therapies that are applied later on, as well as like an increase in difficulty and potential adjustment to new lifestyle changes post-diagnosis. Understanding why this delay exists and also working to address this delay is where Autism Alert specifically comes in. So in this specific study, the present phase of this project involves qualitative interviews with families whose children have initially screened positive for autism and assessing their experiences with Autism Alert, which is a randomized trial of autism family navigation. This project used qualitative interviews to assess experiences accessing autism care for families that both did and did not receive navigation. You might be asking yourself, what is autism navigation? So in our study specifically, we have 2 navigators, and these are people that are responsible for contacting our families in our study, which of there are about 50 and 30 are about receiving navigation. The navigators reach out to them through routine phone calls, and they talk a little bit about like the process that's occurring of them in the midst of getting a diagnosis. If families have any questions about like if there's any paperwork delays or any expectations of them, the navigators are responsible for kind of facilitating that communication to really work to address why these delays are existing, and providing solution to families in the meantime in order to ensure that children aren't like going missing because of delays that are occurring or a wide variety of other things that we're hearing in this interview, which we'll talk about in a second. So our sample in this study, we had parents of children with positive screens and referrals to early intervention services who were invited to participate in qualitative interview with us via email solicitation from our study team. They were compensated $50 for participation in a phone interview, which ranged from about 30 to 60 minutes, depending on the nature of what the conversation was. We had about 6 families that were recruited from 7 primary care clinics in Oregon that we specifically spoke to, and 6 interviews have been completed. Interviews are recorded and transcribed. We have 2 study team members that are going to code all of the transcripts for main themes using in vivo software, which is very fun software. Community members, so an autistic adult and a parent, are going to be providing input and consultation to the coding framework at multiple points during coding. It's really important that we get the feedback of autistic individuals, especially in the study that we are doing. So specific things that I've been hearing so far from the interviews that we've been conducting, because the vast majority of my contribution to this research has been sitting in on these interviews and transcribing them afterwards. We're hearing a lot of frustration from parents about feeling lost in the process. For people who aren't aware, the process of getting diagnosed can vary family to family, but for the most part, for children who are screening positive initially and they're being provided referrals by pediatricians, sometimes they're being provided referrals to like the CDRC in Oregon, which stands for the Child Development Center, and it's like 2 hours away, which means now they have to figure out how am I going to get there, what's lodging going to look like, what's transportation going to look like, which could potentially be one of the reasons that a diagnosis is delayed. They're also experiencing frustration at provider-held misconceptions of autism. I thought this specific quote from one of our interviews was really interesting. One of the parents said, her primary care provider was under the belief that she might grow out of it was one thing. Girls don't get it, it's a boy thing. I can't tell you how many times I've heard that she can't be autistic. She's a girl, only boys get that. And obviously when you're being met with that feedback from your primary care provider, trying to access a diagnosis is not only just more difficult, but it can also be very anxiety inducing. We also are hearing that for one parent specifically, they were doing Zoom appointments, no in-person. How do you evaluate a child over Zoom in front of a computer monitor? She just doesn't do that. So we're seeing impacts of the pandemic also being present in play for the parents that are experiencing delay in getting access to intervention or a diagnosis. Parents are also expressing their satisfaction and with the emotional support that their navigators are providing them, as well as the additional insight that they're being given from providers. These phone calls look and sound like a lot of different things depending on what families are needing. So we're hearing a lot of interesting feedback from them. Parent experiences in this process are varying, but we're getting really important suggestions from families going forward in our study. Phone calls are going great, but we're also getting feedback that maybe text messages might be a really effective way to communicate with families. And we're also being told that maybe navigators should be given more resources so that when parents have questions about where they are in the process or how long it's going to take for them to access intervention, that navigators can give them a more concrete answer. The third and final phase of this project provided necessary insight from parents on their experiences with accessing autism diagnosis and early intervention. Some next steps could include a compilation of the themes from what we're hearing from these interviews from all of our different study phases to develop a guideline for more equitable experiences in accessing autism diagnoses and early intervention services. I want to say thank you to the KZ laboratory team and everybody on the Autism Alert Project, specifically Dr. Catherine Zuckerman for being an amazing mentor. I want to thank members of the URISE and Build Exo teams, specifically my cohort 2 URISE scholars who have really played an important part in the facilitation of my learning. And I want to open the floor up to any questions.
So I had a question. So my younger sister's autistic and she had a really delayed diagnosis. Part of that being my parents being immigrants from Colombia, they didn't really know what autism was. And when she was having trouble in school, parents were just like, oh, it's because you don't get along with your classmates, because you speak Spanish at home, like you need to, it was blamed a lot on other things. So I was just curious in your analysis, are you looking at like cultural differences as well and how they might be providers or other access to resources?
Oh, absolutely. I'm really excited for interviews that are going to be conducted in Spanish to occur, because we're going to really get a lot of insight on what language barriers and like cultural differences and how they're playing a role in a lot of these delays that are occurring. Obviously, if like you're having a difficult time communicating with your primary care provider, if there's like words that you don't know how to communicate and relate to, it can be really hard to communicate your concerns. And on top of that, it can be really hard for your provider to also communicate their concerns with you as well. There's a lot of different things that go into it, but that's definitely something that I'm looking forward to hearing from our interviews going forward.
Not sure if this question is relevant, but I've heard that boys are diagnosed more than girls and girls are diagnosed at a later age. Do you know why this is?
You are absolutely right about that. And there's a couple of different things that play into this. Number one, stigma and taboo is a lot more powerful than you would think. And it absolutely does impact medicine. There's no way that like medicine can, I guess, well, medicine absolutely can like circumvent all of it, but it definitely is impacted by it. First and foremost, a lot of the children that are screen positive that are girls, there's a lot of excuses that can be made as to like why they're exhibiting certain behaviors or why certain concerns exist for the fact that they might have autism. It's very easy for either the doctor or like the parent to say, girls are quiet, like that's not really a concern. It's not like she's exhibiting any behaviors that are like interrupting her behavior in school or like interrupting how she's learning. So the less like interruption to the child's like day-to-day schedule, it can be a lot easier for them to like convince themselves either that their child doesn't have like a concern or that even the positive screen isn't important. Or sometimes it can also be that pediatricians believe that the family isn't ready for a diagnosis or that the diagnosis might interrupt like that child's overall care. I'm really excited for us to hopefully be able to talk to providers as well and kind of get like their thoughts as to why they are referring certain children and not referring others. I feel like that'll really help us also understand why those disparities between boys and girls exist.
And to add to that, just because I do have autism and so I'm naturally just kind of a nerd about it too. One thing that I've been reading some research about is that girls tend to be more successful in masking or like acting neurotypical in social situations. And so that could be another contributing factor. And then also on top of that, just my anecdotal experience is that in like pursuing a diagnosis in adulthood, there straight up being no resources for adults with ASD. And so all of these support structures are just geared towards children. And if you're an adult, you literally cannot have access to that. And so that's another thing that can really get in the way once you're past a certain age.
Absolutely. And I really appreciate that. Thank you.
I'm an adult who suspects they have autism, but cannot find any resources. So I really relate to that comment. My question was about, with regards to the gender split in diagnosis of children, did you see any more prevalence of like female caregivers bringing kids into this study? Or did you see any of the genetic connections that get talked up? You know, did you see autistic parents that didn't know they were autistic?
These are really good questions. I actually really liked going through our caregiver surveys and kind of getting an idea as to who these people were that were bringing their children into the study. We have a lot of parents that are mothers. That's very common. A lot of the people, especially that we're talking to in interviews, are moms that are avidly caring for their kids and have their kids around when these interviews are occurring. I think that's very interesting. I don't know actually if there are any parents involved in the study that themselves have been diagnosed with autism, but that's very that is something that we should be looking into. Like I'm interested in that. Thank you.
Is it typical when there's that initial referral for families to have a navigator, or was that just a feature of this study?
That was a feature of this study. It's interesting to hear the differences in experience between the families that received navigation and didn't in the randomized trial, because we can definitely see an impact of the navigator so far. And I'm sure as interviews kind of go on, we'll start to hear a little bit more about what the differences specifically were between people that received navigation and not. But it's about 30 people that were assigned navigators and about 20 families that did not receive navigation at all.
So in addition to looking at their experiences, you'll be determining things more objectively like the time frame or other indicators.
Yeah.
I have questions about genetic components. Do you know if it is dominant or recessive?
That's a really good question, actually. I do not know the answer to that, but that is something that I will look into and actually get back to you on.
Is there a place for an adult to go to find out, or do they just go to their primary care, like if they have autism?
That's a really good question. Our specific study, since we are in Dornbecker, is focusing on children, but if you do have concerns for yourself, having a conversation with your primary care provider about what that would look like for you is definitely a conversation that you should partake in.
So there you mentioned there were recommendations for the navigators to know more, basically.
Yes.
So is that because they were like, this is just getting started and it's a new thing and there are no existing experts, they're just hired for the study?
So for example, our navigators don't have like Epic access, which means that if they're looking at like, if a referral has been put in, it takes a while for them to like reach out to specific people to have them check in if they have Epic access versus if they had like access themselves. So when I say know more, I mean give them access to more resources so that way they can answer questions a little bit better, like looking it up on Epic and having that access themselves, rather than relying on like a doctor from a different clinic in a different place to email them back so that way they can call the family again and then let them know this is the answer to your question. Kind of delays the process, which is a very common concern we're hearing from parents.
So some systemic things that you
Yes.
can address.
Absolutely. Our navigators are very smart people.
What kind of training of your navigator? Like, is there a standardized process that they go through in the lab?
There is like a standard training that all the navigators are given. For the most part, we have a contract with Help Me Grow, who kind of facilitates like finding the navigators for us, and like I guess we have like training that we give them. A lot of it is kind of informal too. It's like conversations that they have like with us, and the check-ins that we do with them. So like if there's any questions about like how to engage with a certain family or any questions that they have about a question or concern that a family raised, the routine check-ins that we do with our navigators are kind of like where we go from there. But
Okay, thank you for. So our next patient coming right up is Grace Barra, and she will be talking about patient provider language concordance for Latino patients.
Thank you. Thank you, Dr. Keller. Hello, everyone. My name is Grace Barra. My pronouns are she, her, hers. I'm currently going into my 4th year here at Portland State University with a major in public health studies, and I am part of cohort 1 for URISE. I have been working in collaboration with OHSU and my research team, which consists of Sara Diaz-Anaya and my PI, Dr. Brodani, to construct this research study, which looks at the association of patient-provider language concordance with healthcare comprehension among Latinos and Latinas in Oregon. And this study is still a work in progress. So I'll be starting off with giving some background information, and I'll be talking about the growing Latino population in Oregon. So according to the 2020 census, it was shown that there was a 31% growth of the Latino population over this last decade. And Oregon, nearly with every other state, showed that the Latino population growth rate was outpacing the overall growth rate of each state. And with that same 2020 census, it was also shown through the statistics that 12% of Oregon residents speak a language other than English at home. And from this 12%, 6% expressed that they had difficulty speaking English. Next, I will talk a little bit about language barriers in healthcare. So this happens when the provider and the patient don't speak the same preferred language of the patient. This creates challenges in achieving things such as high levels of patient satisfaction with their care, high levels of patient comprehension, and being able to provide high quality care for patients, as well as maintaining patient safety. It is hard as a patient that only speaks Spanish and you're talking to a provider that only speaks English. It's hard to go home and have to take next steps, such as taking medication, and you didn't understand the directions that your provider gave you. That's when things such as patient safety are compromised, just because the patient doesn't know how to take these next steps. Next, I'll talk a little bit about language concordant providers, and this is when the provider and the patient speak the same preferred language of the patient. With language concordant care, this allows us to have an enhancement of trust between the patient and the provider. They're able to create a better relationship. This also optimizes health outcomes and allows for greater patient satisfaction during their healthcare visits. In studies that I've read, articles that I've read, they were looking at using translators, so having a third party with this, with the communication between a patient and a provider. And it was actually shown that it increases the cost of care, which makes it less financially accessible for families to get care. It has also shown to increase the length time of a visit. So that's where like patient satisfaction levels go down. So the purpose of this study is to understand the local Latino community's need for bilingual healthcare in order to allow better access to healthcare. Our team hypothesizes that the language ability and the presence of a language concordant provider is associated with greater healthcare comprehension and satisfaction of patients. For our methods, our team has created a cross-sectional study, and we created a 20-item survey. The questions within the survey were from previously conducted surveys and research studies, also validated scales, and we also asked some demographic questions. For our recruitment, we will be recruiting at the General Consulate of Mexico, which is just a couple blocks down from Portland State, and our goal is to recruit 500 participants for our study. And for our eligibility criteria, we ask that everyone who participates is at least 18 years or older and has had a healthcare visit within the last 12 months. And here's a picture of the General Consulate. Here are some example questions from the survey that we constructed. So number one, during the visit, did you understand everything the doctor and nurse said? Most of what the doctor and nurse said? Some or only a little of what the doctor and nurse said? Number two, I feel that communicating with my healthcare team in my primary language is important. And number three, if given the choice, I would prefer to be cared for by a healthcare team that speaks my native language instead of using an interpreter. As for an agenda for where we are in the study right now, I'm currently submitting all my documents to the IRB and receiving some feedback. Recruitment is hopefully going to happen in October. Results are anticipated to be done with in early February. And once we have our results and everything, I hope to share that with the General Consulate of Mexico and local partners and other community members. As for future plans, I hope to complete a peer-reviewed publication of my study to be completed summer of 2023. For our study's implications, our results can be used to advocate for access to language concordant care in Oregon, as well as contribute to improving health equity and outcomes for Latinos in Oregon. I want to take this time to thank you all for listening to my presentation, as well as give a special thanks to my PI, Dr. Blair Darney, who has always supported me through constructing this research study and learning so much more about my interest in research. So thank you all. Yes.
First, I wanted to say that I think this is some really important work. I, from personal experience, know how difficult it is, and speaking English in the first place in this country, so accessing healthcare is really difficult.
I'm just curious if you have any thoughts on like interventions that you might have, because I know like I work in a hospital. It's very rare that I come across another Latino doctor, you know, so that's not quite something I see a lot. And also I know that a lot of Latinos and other people who don't speak English as a primary language, they hesitate in asking for interpreters because even though they might not speak the same language, they can be body language, and they're scared of, you know, staff being annoyed or put out, and they worry about how that might affect their care. So I'm just curious about like what kind of maybe like interventions or solutions you have.
Oh, yeah, of course. I think it's really important to start off with like the education side of it. So with doctors, like having the program be placed to where they do learn like another language, or that's super accessible to them as they're going through med school. Second, I would recommend showing these results or any other results that support this idea to hospitals, clinics, showing that it is important for the community that they have somebody that looks like them, that will be treating them, that can speak their language. I have also worked in a hospital and I see how sometimes they're carrying like the computer monitors that have the translators, and I mean, even just thinking of having to talk through someone through a computer, like, and about healthcare, I feel like we can do a lot better to have people of color in these positions to where having to carry a computer around isn't going to be necessary anymore, because there'll be someone on the floor that can attend whoever needs help. And that just goes for more than Spanish. I feel like every language should be represented, every community, every ethnicity should be represented in especially the healthcare field. So thank you. Good question.
Yes. So you mentioned that overall wait time can have a decrease in patient satisfaction. Will you be looking at, or will you consider overall wait time, like an office visit waiting for the doctor versus the time a patient actually spends with their doctor, and see if that has any significance?
Yeah, for patient satisfaction, we do have like a scale that asks like, how would you rate your visit, you know? But I do know, I mean, from experience too, being in a doctor's office, having to wait so long is like kind of discouraging on wanting to go, because you're like, okay, now I have to set 2 hours out of my day and I'll only talk to my provider for 30 minutes out of the 2 hours that I was there. So we're not looking at that, but that's definitely good, like future steps, what other studies should look at. So thank you.
Yes. Yeah, you mentioned that bringing an interpreter in will increase the cost of healthcare. Does the lab have any suggestions when, and like for me personally, I think the responsibility should be put on medical industry to pay for that fee. So is there any suggestions and ways in which we take that responsibility from patient and put it on these institutions?
I think that comes down to policy and having to make that change. Start off in Oregon, like, okay, we're gonna set money as a state to pay for these expenses, to pay maybe bonuses so people can see, oh, if you're bilingual, we'll give you a bonus if you work here. So I feel like that can be future steps for us in policy, and people who are in power that can choose who's gonna work there, the workforce team. So I definitely think that could be next steps. Thank you. Yes.
As somebody who's created surveys, I'm impressed that you have just 20 items. You've kept it focused.
Yes.
Can you just say something about what it was like to make those choices and, you know, weigh the different factors like, you know, the response time and you know, the information that you really had to have versus wanted to have?
Yes, the way we constructed the survey, I started through literature review and started taking notes of what were some good questions that each survey included, what were the best ones. Because at first it was my thought to find one survey that I wanted to use all the questions from and just repeat the same study. But there was just so many studies that I came across and I was like, okay, I like this question, I like this one. And that's kind of how it all came together. And also, we had to cut it down to the 20 questions just because where we are recruiting at the General Consulate, we go recruit while they're waiting to be called up to do their documents or whatever they're there for that day. So we also don't want it to be so lengthy that they won't be able to finish the survey. The previous scholar that was in this RLC did a similar one where they they were looking at reproductive autonomy, but they did a survey. And I had to keep in mind that it couldn't be so long because with that experience and helping her recruit, I kind of knew how long people were in the wait area and how long my survey could be. So those factors played into what I chose, what questions I chose, and how many I did. Thank you. Yes.
I'm really interested in how you all are going to separate the people for like the various reasons for why they want a provider that speaks their own language. So like for me personally, I would love if my doctor spoke Punjabi because they're probably also Punjabi and from my own community. But I know for some people it might just be because they don't want that like language barrier. So I'm interested in if that separation of like why people are wanting a provider that speaks their own language, whether it's because they're from their own community and they understand cultural nuances, or like if that difference in why people are answering yes, I want a provider my own language.
No, yeah. Well, one thing that we do is we provide our survey in Spanish and English. Most of the time it will be taken in Spanish, but we do have that opportunity to take it in English, and it just depends what everyone's comfortable with. Usually people that have immigrated here and been in the US longer can be more comfortable with speaking English, but they still might feel more comfortable talking to their provider in Spanish. So looking at how long someone has been in the US and looking at how that correlates with whether they wanted Spanish or English care. If it was important for someone that speaks their native language to be their provider. So things like that we take in account. Thank you. Yes.
As far as location of the study, why did you end up choosing the general hospital instead of like the private hospital or other like central Pacific?
Yeah, well, we chose the location just because there is people from all over the state that come here and they come for different reasons, different backgrounds. So it was important to make sure to grab the community, a good portion of the community that will represent everyone. So we didn't just want to pick like a hospital like OHSU here and only have the Portland community show up to this hospital. So we wanted that diversity in our study. So this was a good spot for us to pick. Yes, thank you.
It was an excellent presentation. We are on to our last presentation of the day. This is another URISE trainee. We've been working with Dr. Darney. So I'm pleased to introduce Nancy Ledesma, who will be talking about Medicaid expansion for immigrants in Oregon.
So hi, I'm Nancy Ledesma. I am third year public health studies major, and I'm part of the second cohort for URISE. So I have the pleasure of working with Dr. Darney and my colleague. So just some background information on what is Medicaid. So it is a government-funded health insurance program that covers low-income families and individuals. However, undocumented and recent immigrants are excluded from the federal Medicaid programs. So Oregon did release an insurance program to cover these individuals. And along Oregon, California, Illinois, Massachusetts, and New York, and Washington are some of the states that have extended these benefits to immigrants, so they are able to be covered and receive those benefits. Just continue on. So the legislation that passed in Oregon is called Healthier Oregon. There's another way to fill the gap and use state funds to extend coverage to undocumented and recent immigrants. Oregon passes legislation in July 1st of 2022, and children under 19 will continue getting benefits under Cover All Kids. And since it is, we are all limited on funding, it is specific to the two age groups. So only people of 19 to 25 and 55 and older are eligible to receive these benefits. And so the objective of the study is to identify individuals that are aware of Healthier Oregon, their eligibility, and whether barriers to enrollment persist that are keeping them from accessing these benefits. And just for our hypothesis, our team does expect there to be a high number of Latinos unaware of this Health Your Oregon program, as it is still a fairly new program that just went in place this summer. Our team also expects there to be a lot of Latinos confused about their eligibility, not applying for fear of affecting their immigration status or their fear of their family and friends. And just so the methods to for our study is, we will also be recruiting at the I will construct the Spanish to English cross-sectional survey. Just some topics that will be included in the survey will include awareness of the program, eligibility requirements, knowledge of the application process, and some possible barriers are keeping them from accessing. And I will also be recruiting at the General Consulate of Mexico. The goal is to gather 500 survey participants and to recruit self-identifying Latinos over the age of 18. And for our products today, we held our meeting in July with the General Consulate of Mexico to introduce this topic to them. I'm also doing literature review at the moment to just expand my knowledge on this program and other programs alike. And I have developed a research objective, questions, and hypotheses. And I am reviewing published surveys to develop a study protocol and survey. And just to give a visual example of what future plans look like, I hope to be submitted to the IRB in winter or spring of 2023, begin data collection in the summer of 2023, and share our results with the Consulate and Oregon Health Authority in fall 2023. And by winter or spring of 2024, I hope to have be working on my analysis and manuscript writing. And some implications, our results can be used to improve outreach to the Latino community about the Health Your Oregon program and improve access to healthcare for Oregon Latinos. So it is important for them to be able to access more benefits and lessen the amount of uninsured people. Just some references. And I want to thank my PI, Dr. Garney, for helping me and guiding me through this project.
So if I remember, one of your hypotheses was that Latino would not be aware of the program at the same level, not know their benefits. Are you collecting data from other locations as a comparison?
No, so we will only be collecting data at the consulate. So just to clarify the hypotheses, since it is a fairly new program, a lot of people are confused about their eligibility since it is specific to age groups. Some are also afraid of it affecting their immigration status. And also just, it is a new program, so not many people know about this program, so they might not even know that this program exists. So that's our hypothesis.
So I just imagine that like I'm not going to be scared of applying for this program, and just in case of immigration status is disclosed, your legal retributions, you know, anything about what protections that are offered to them, or how you can really encourage them to apply despite those fears.
So the purpose for this is to clarify that this is not a public record. So there's no way for them to be identified as undocumented. So that's our hope, is to spread that misinformation or clarify issues so that they can access those benefits and not be afraid.
Yeah, this is really nice work, Nancy. I was excited when you mentioned that the results from the survey would be kind of presented to the Oregon Health Authority. Can you talk a little bit more about how studies like this can actually change sort of public service announcements and the way that people are informed?
So our hope is to better the outreach methods. So as a way to diminish misinformation or just confusion. So sorry, I'm blanking out. Yeah, it's just our goal is to
clarify and diminish those confusions.
So I'm curious, in doing those surveys at the consulate, are you planning to also ask people while they're waiting in line? And have you found that to get a good response rate, you need to offer any incentives, or is it just because they are there and have nothing else to do that it doesn't really require any additional expense to get a large sample like that?
So we aren't offering any incentives, but since people are waiting there, they're really it'll be a good way to pass time. The good thing about recruiting there is since there are also a lot of Spanish speakers around, if they do have some confusion or they're just unsure of a question, they are able to approach people and ask for help.
So with the healthier ordering program, the age groups, do you expect or how do you plan to move forward working with age groups that do not qualify for this program if they're in between that 25 and under 54 range?
For that, I don't really know exactly since the age group is not up, it's up to funding. But hopes is to reach people that may not qualify, but maybe they know people that are undocumented and could qualify for these benefits. So it's a way to get from one person information from one person to another. So just better improve our outreach.
Yeah, a quick question regarding like the population of the general Mexican continent. Is it typically people from other Latin American countries as well, or just from Mexico?
It's people from different countries, so it's not specific to one country. So we have very diverse.
Okay.
Thank you for the questions.